guys, I'm Alex, I'm the critical care educator here at Kettering Health Dayton. Today we're going to be talking about what we need to do in the event a patient who has a trach and it gets dislodged. First, we need to make sure that we have all the appropriate supplies at the bedside. One, we want the arbitrator hanging up on the wall. There's also one in our trach box, and we want to make sure that we have the correct size trach. So our patient today is going to have a 6, and so we want a size 6 at the bedside, but we also want one size lower. So we would get a size 5, and we make sure size 5 is at the bedside as well. We want to make sure that we have a 10 cc or 20 cc syringe to inflate our balloon. Lubrication for inserting the trach. We want to make sure that we have fresh trach ties. We want to make sure that we have suction set up. And most importantly, we want to make sure that we have our ambu bag and a mask for our ambu bag as well. So, walk into our patient's room, we perform our hand hygiene, and we notice that our patient's trach is dislodged and their oxygen is lowering. So we need to act quickly. We have about 20 seconds to replace the patient's trach. So what do we need to do? Well, we're going to grab our regular size, or size that the patient has. So this guy has a size 6, so we're going to try to place a size 6. We're going to grab our obturator. There should be an obturator in each of the trach boxes. But we also want to make sure that at the bedside. Once we open up our box, we're going to make sure that our balloon doesn't deflate, doesn't have any holes in it. So we're going to place 20 cc's of air into our balloon, and that is how much air that is needed in these cups. And we're going to just assess, make sure that there's no air leaks. Force it in there. If I force it in there, it could cause trauma to the trach site, and the skin surrounding the neck, the chest, and the face could develop crepitus or subcutaneous emphysema. So say, for instance, I'm meeting that resistance, my stoma hole is closing, because your stoma holes can close very quickly. Then I'm going to attempt to grab my size 5, my size smaller, reattempt placing the trach. So let's say that all went well and we got our trach placed. Now we're placed, and I can take the obturator out, and my patients are 2 sats or low, bag my patient, and connect right to the trach. Also, we'll make sure that our oxygen is connected. At this time, after you get our trach in place, you want to inflate the balloon as well. Now, say for instance our trach doesn't go in. We have complete difficulties, we're unable to get it in. All that we need to do at that point is to bag the patient. We need a ventilator. So we'll take our ambu bag. Again, we will make sure that we're hooked up to oxygen. We'll turn our oxygen all the way up to 15 liters. We'll get this placed correctly, and I want to take a glove thumb underneath the stoma site while we're bagging. Ideally, fresh trach. We cannot replace, and if it dislodges, we cannot replace the trach up to 7 days post-surgery. We guarantee to place the trach. So if the trach dislodges and they're a fresh surgical patient, then we just back the patient until ENT arrives. If the patient has had a laryngectomy, we want to make sure that we get pulmonology in right away, because bagging the patient will not provide appropriate ventilations for where the surgery was. Hopefully this was helpful. If you have any questions, please feel free to reach out to myself